So the misconception is always there that posterior segment trauma has an unpredictable outcome. But in reality, it is not exactly the same, because trauma purely follows the law of physics, but it doesn't follow the segment concept that we have given the segment, anterior segment or posterior segment. But only one thing, the assessment is difficult and intervention is more cumbersome, but it is not unpredictable. The basic clinical assessment necessary, whether it's a reversible or irreversible damage, that we have to know. Then whether involvement of visual axis is there, with the presence of an infection, presence of intraocular of foreign body, or an associated reaction, that we have to assess. And some other prognostic factors. What is the initial visual acuity? It depends on the final outcome on this. The type of trauma, whether it's blunt or penetrating, and the site of trauma, whether the macula is involved, how big is the injury, and when it happened, basically the duration. The diagnostic helps that we need some time. That ultrasound gives vital information in many situations, because suppose you see a case of retinal vitreous hemorrhage, but you do not know whether retinal detachment is there or not. But with ultrasound you can find out and you can prognosticate, and this is very helpful for this kind of situation. VEP is crucial in some situation. If that PL is doubtful whether a patient will regain back the vision after treatment or after surgery, but VEP can be give you a prognostic indication that you should go ahead with this particular case, or whether you should abandon this. And ERG is very vital in some situations. A long back, suppose there is a small intraocular foreign body iron particle, patient maintains 6 vision, but by 6 months or 1 year, he is coming in with sclerotic change. So you never know when the patient cannot give a proper history also sometimes. So by ERG you can find out the retinal function and whether a small foreign body was there or not. FFE is helpful if traumatic macular change is there, or viral rupture or CNBM subsequently, and subtle changes in macula can be detected by OCT. Basically, the trauma can be either blunt or penetrating. So in blunt trauma, if it is Barlich's edema, you have a good outcome. If it is a retinal dialysis related retinal detachment, even the outcome is good. Vitreous hemorrhage, suppose macula is not involved, healthy macula, but only vitreous hemorrhage, even you have excellent outcome with treatment. Choroidal rupture can give an average outcome, but if it is away from the macula, even with choroidal rupture and subretinal hemorrhage, you can maintain a 6 vision. But if it involves the macula, center of the macula, then of course the vision will not be very good. Posterior lens dislocation, even the result will be good. You can do a vitrectomy, remove the lens, and you can put a IOL there. Traumatic macular hole is having poor prognosis, and if there is traumatic optic neuropathy, even the prognosis is poor. In case of penetrating injury, again, it is only vitreous hemorrhage without any associated retinal detachment or partial detachment. Macula is healthy, then you will have excellent visual outcome. Fresh retinal detachment, the result will be good. Suppose it involves macula maybe a week, you will have an average vision. But if long-standing RD, your vision will be poor. But fresh RD, you can say it's average vision. If GRT related RD, outcome is not that good. But anyway, you can manage this situation. Globe rupture can give you poor outcome. And intraocular foreign body, again, if your other structures are fine, only the foreign body, removing the foreign body, you can have good vision. But if already some other structural damage is there, even vision may not be as par with your surgical what you have decided. But if it is associated with some condition like endophthalmitis, even poor, and suppose the trauma has caused endophthalmitis, traumatic endophthalmitis result poor than post-op cases. And even I told you that intraocular foreign body with endophthalmitis, even more challenging. In these cases, you have to do early vitrectomy and remove the foreign body. OTS gives a guideline for treating these trauma cases. So initial vision and tissue diagnosis is recorded, and point value are assigned from OTS table. So OTS determined by subtracting value of tissue diagnosis from the initial vision. And the high OTS tends to indicate better prognosis. So by 6 months, what will be the visual outcome? We can have a rough idea from of the OTS. So if we can remember this, we can have a short OTS short. We can explain the patient what will be the outcome, probable outcome. Because trauma cases always it's very difficult to handle from the beginning to the end, because it can also involve the legal procedure sometimes. So some important prognostic tips that I want to share. If you suspect this inflammation or infection, in penetrating trauma, if you see hypopyon, think of endophthalmitis. So you treat in that line. And if you see this best corrected vision is inappropriate to the amount of vintage hemorrhage, hemorrhage is not that much, but vision is grossly deteriorated, then you also suspect some other structural damage or involvement of the optic nerve. And as I told you, iron foreign body, if it is small also, and if vision is good, still we have to go ahead with early surgery. And always you remember that this penetrating trauma-related retinal detachment, even if you do surgery, proper surgery, the recurrent retinal detachment rate is high and BBR is high. So these are some important tips, and I thank my other co-speakers. We'll continue this instruction course. Thank you very much. So I invite the next speaker.